This is Will Blakeney from Royal Perth Hospital and UWA, orthopaedic surgeon, giving you a presentation on the shoulder. This is what we'll cover in this presentation. Firstly, having a look at the anatomy, or the refresher of the relevant anatomy for shoulder conditions. Then we'll have a look at pertinent history and examination, findings in shoulder pathology, then some common conditions and management of these conditions. Again, we'll start with 3 small cases. This first one is a 35-year-old carpenter. He injured his shoulder reaching out his arm to catch a falling roof beam. He felt a rip in his shoulder and severe pain. And since then, he's been unable to lift his arm above his head and has had a constant ache. Second case is a 19-year-old footballer. He went up to take a mark. As he was taking it, he was hit in his back from behind, then landed awkwardly on his arm and felt his shoulder pop out. You can see the image here, what his shoulder looks like now. Third case, a 78-year-old female. She's had worsening shoulder pain for the last 12 months. Associated reduced range of motion. She says she has crunching and creaking in the shoulder when it moves. So have a think of over those 3 cases while we go through some of the shoulder anatomy and pathology. Starting with the bony anatomy, the 3 main bones that make up the shoulder joint are the humerus, the scapula, with the glenoid portion making up the glenohumeral joint. Then the clavicle is also involved with the acromioclavicular joint. So when we think about the shoulder joint, generally we're talking about the glenohumeral joint, but the other things to consider are scapulothoracic joint, where a lot of the shoulder movement takes place. The AC joint or acromioclavicular joint, SC or sternoclavicular joint are also possible places where pathology can occur. The shoulder joint is unique in the wide range of movement that it enables. This is developmentally so that we are able to place our hand in space anywhere around our body, which enables humans a wide range of functional abilities. It achieves this range of movement at the cost of stability. The humeral head is very large compared with the shallow glenoid fossa. Some of the stabilizers around the shoulder, which help offset the stability caused by the large humeral head in the shallow glenoid fossa. It can be divided into static stabilizers and dynamic stabilizers. The static stabilizers include the glenoid labrum, which is attached to the circumference of the glenoid, deepening it and enlarging its size. The joint capsule, coracoacromial arch, made up of the coracoid, coracoacromial ligament, and the acromion. There's also the coracohumeral ligament and the capsuloligamentus structures pictured here, which include the superior, middle, and inferior glenohumeral ligaments. The dynamic stabilizers are basically the muscles around the shoulder, rotator cuff, long head of biceps, the deltoid, most importantly when the arm is elevated above 90 degrees, and the scapular rotators, which move the scapula and therefore glenoid into a stable position. Again, here you see a better picture of the glenoid labrum. We see the coracoacromial arch, including the coracoacromial ligament, and the corticoclavicular ligaments, which are important for AC joint stability in combination with the acromioclavicular ligament. The muscles of the rotator cuff, to refresh, are the supraspinatus, which abducts, infraspinatus and teres minor, involved in external rotation, subscapularis at the front, which is an internal rotator. Taking history for shoulder problems. Pain is the most common symptom. However, it is important to differentiate different types of so-called shoulder pain, as not all shoulder pain is necessarily from the shoulder joint. If the patient points to the top of the shoulder, you can think of acromioclavicular joint pain. If the pain radiates up to the neck, think of neck pain. Pain from the shoulder joint and rotator cuff is typically felt over the front and outer aspect of the joint. It can even be as far down as the middle of the arm. Don't forget referred pain from mediastinal disorders, including cardiac ischemia, which can present with aching in the shoulder. Next, weakness may appear as a true loss of power, suggesting a neurological disorder, or a sudden inability to abduct the shoulder, more in keeping with a tendon rupture. Between the extremes, there is also weakness in performing certain movements, and weakness secondary to pain. Instability symptoms can be gross, such as a patient tells you their shoulder jumps out of its socket when they raise their arm, but often they can be more subtle, such as a click or jerk when the arm is held overhead, such as when a volleyball or tennis player goes to serve. Stiffness can be progressive and severe, which may be the case in adhesive capsulitis or frozen shoulder. Swelling can be as a result of a joint effusion or muscle or bone swelling, which the patient won't be able to differentiate. Deformity may be a result of muscle wasting or prominence of the AC joint in AC dislocation, winging of the scapula, or simply an abnormal position of the arm. Loss of shoulder function is usually expressed as difficulty with dressing or grooming, inability to lift objects above shoulder height or work with the arm over shoulder height. Examination, again the classic look, feel, move special tests of orthopaedics. After observation with the shoulder, we should see the patient's active range of motion and compare this to passive range of motion, palpation, and then resisted muscle testing for the rotator cuff. Special tests for biceps pathology, AC joint, impingement, and instability should all be covered in your musculoskeletal clinical examination unit. Differential diagnosis of the painful shoulder. You must always consider referred pain syndromes, cervical spondylosis, mediastinal pathology, cardiac ischemia. Next, joint disorders, either glenohumeral arthritis or acromioclavicular arthritis. Bone lesions, which will include infection as well as tumours. Rotator cuff disorders, tendinitis, cuff rupture or frozen shoulder. Instability, which can either be frank dislocation or subluxation of the joint. Specific nerve injury would be a suprascapular nerve entrapment. Back to our first case. This is the typical presentation that you would get with a rotator cuff tear. Cuff pathology will cover everything from supraspinatus, impingement and tendinitis through to tears of the rotator cuff, acute calcific tendinitis, which you see pictured in the radiograph here, and biceps pathology, which includes tendinitis and or rupture. Presentation can vary depending on whether this is an acute cuff injury, such as in the case vignette, or chronic. Generally, acute traumatic injuries are seen in the younger patient, whereas the elderly patient tends to have a chronic cuff degeneration without a specific incident causing the pain. But pain and weakness are the two most common symptoms. Examination findings include pain with range of motion, specifically in the direction of pull of the torn tendon. There is also pain with resistance testing. Include the empty can or Job's test and the push-off or Gerber's test. If there is a large full-thickness tear, the patient will present with a drop arm or pseudo-paralysis where they can't lift the arm at all. If there is impingement, the patient will have a positive Neers or Hawkins test. This video demonstrates a lady with pseudo-paralysis. She has no active forward flexion of the shoulder, but can achieve full range passively. We'll generally get an X-ray on all patients. Ultrasound and MRI can be used for imaging of the cuff. MRI is the gold standard. X-ray is important for a number of reasons. This supraspinatus outlet view allows you to see the acromial morphology. The Bigliani classification is illustrated. 2 and 3 are associated with impingement of the supraspinatus tendon as the arm goes into abduction. We can also see superior migration of the humeral head, which is seen in chronic cuff tears. Here you can see the progression from grade 1 to grade 5. When a patient has a massive cuff tear, there's nothing to hold the shoulder in the joint, so it slowly migrates superiorly. Then arthritis develops, and you can see in grade 4 and 5 the humeral head starts to articulate with the acromion and then wears the acromion as well as the glenohumeral. MRI is the gold standard for rotator cuff imaging. It will show you the size and extent of the tear as well as the amount of retraction as demonstrated in this picture here. It will also demonstrate any atrophy of the muscles. Management of rotator cuff pathology. If it is simple tendinopathy or impingement without a tear of the tendon, and then we'd initially start with conservative treatment, which includes physio, subacromial cortisone injection. Similarly, partial thickness tears up to 50% of the tendon width, we would do the same. If the patient's not responding to these conservative measures, then we'd consider a subacromial decompression. In full thickness tears and some high-grade partial thickness tears, then orthopaedics referral for consideration of rotator cuff repair is advised. Nowadays we tend to do rotator cuff repairs arthroscopically. Pictured here you'll see a typical configuration of a double row repair of the supraspinatus tendon. Shoulder impingement is another thing we see in the spectrum of rotator cuff disorders. Pictured here you see coronal sections through the shoulder that illustrate how the subdeltoid and subacromial bursa, as well as the supraspinatus tendon, can be irritated by impingement under the coracoacromial arch or an arthritic acromioclavicular joint as the shoulder goes into abduction. On the left you see the joint at rest, and on the right the shoulder in abduction. Number 1 is the supraspinatus muscle, which becomes the supraspinatus tendon, number 5. 2 is the AC joint. 3, the subdeltoid bursa. 4 is the deltoid muscle. You can see there's very little space for the bursa and tendon as the shoulder goes into abduction, so any bony prominence or spur on the acromion is likely to cause pain. Initially, patients present with bursitis, which can then lead to tendinitis, partial tearing of the tendon, which can then progress to full thickness tears. Surgical treatment is an arthroscopic subacromial decompression, where the acromial spur is burred back, the coracoacromial ligament is released off the anterior acromion, and a bursectomy is performed. This then provides space for the tendon in the subacromial space during shoulder abduction. We should also mention frozen shoulder or adhesive capsulitis, which is in our differential diagnosis. This usually presents with pain as the main feature, often more than 3 months duration, with progressive loss of range of motion. Generally, patients are over 40. It's more common in females. Some risk factors are hypothyroidism, diabetes, and any shoulder injury which may have led to immobility. On examination, there is limited active and passive range of motion. External rotation is often the first to be affected and will be less than 50% of the other side. Differs from cuff pathology, where passive range of motion is still maintained, whereas with a frozen shoulder there is a definitive end point. Pictured on the right, you see what happens in a frozen shoulder. The pathology is in the joint capsule, which becomes inflamed, thickened, and constricts. Frozen shoulder classically is described as having 3 stages. The freezing stage is the initial stage where the pain is most severe and range of motion is beginning to decrease. Then the patient enters the frozen stage, where pain is less intense, but the shoulder is extremely stiff. The final stage is the thawing stage, as the patient's range of motion returns as the adhesive capsulitis resolves. The natural history of frozen shoulder is to go through these 3 stages, and it will eventually resolve on its own. However, it may take up. The diagnosis of frozen shoulder is usually a clinical one. Maybe worth doing an x-ray to rule out arthritis, which is another pathology which presents with stiffness and decreased active and passive range of motion. Ultrasound or MRI may be used to rule out cuff pathology. Management first consists of education, explaining to the patient the natural history of adhesive capsulitis. Most patients aren't happy to wait 2 years to let things resolve on their own, so there are a few options to try and speed this process along. The first is an intra-articular cortisone injection. Important to differentiate this from a subacromial injection, which is often given for impingement or subacromial bursitis. The pathology of the shoulder is in the joint capsule, which becomes inflamed and thickened, so the injection needs to be into the joint itself, or it will be of no use. A small percentage of patients that will go on to an interventional procedure. This may be a manipulation under anaesthetic, where the patient is put to sleep and the shoulder is manipulated, tearing through the capsule and releasing the tight, thickened capsule, allowing range of motion again. The same result can be achieved with an arthroscopic release, where the surgeon divides the capsule using arthroscopic instruments. Moving on to case 2, the footy player, which you all should hopefully have realised has a dislocated shoulder. Initial management is first to reduce the shoulder dislocation. It's often best achieved under sedation. Generally, we immobilise the shoulder for a period of 3 to 10 days in a sling, but it's important to not immobilise them for too long, get them seeing the physio who focuses on restoring strength of the dynamic glenohumeral stabilizers, all those muscles that we previously mentioned that provide stability to the shoulder. With early rehabilitation, the patient should be able to achieve pain-free range of motion within 2 to 3 weeks, with the return to sport possible in 3 weeks. Unfortunately, that is often not the end of the story, with many patients going on to have recurrent dislocations. This is because the damage done during the initial dislocation to the static stabilizers of the shoulder leads to stability and ongoing problems. The 2 main lesions that we see are the Bankart tear, which is a labral tear of the antero-inferior labrum, as more than 95% of shoulder dislocations are anterior dislocations, as the head of the humerus exits the joint anteroinferiorly, the labrum tears with it. The Hill-Sachs lesion is the bony lesion you see pictured here, which is produced by the posterior humeral head hitting the anterior glenoid rim, causing an impaction injury. With increasing dislocations, this Hill-Sachs lesion will become bigger. The anteroinferior glenoid will also start to have bone loss, which means that when the arm is positioned in abduction and external rotation, the humerus will pop out the front quite easily, as you see pictured here on the right. The two main surgical options are the arthroscopic stabilisation or Bankart repair, or the Latarjet procedure. With an arthroscopic stabilisation, the surgeon repairs the torn labrum back onto the glenoid using suture anchors. The Latarjet procedure is named after Michel Latarjet, who first reported on a case back in 1954. There have since been many variations of his procedure. The procedure is a transfer of the coracoid to the anterior glenoid. It is held with two screws. It has three mechanisms of action. First is restoring the bony defect in the glenoid. The second is the repair and reinforcement of the anterior capsule using the coracoacromial ligament, which is left attached to the bone block. The third, and probably the most important, is the sling effect of the conjoint tendon. It's left attached to the distal coracoid. And you see as the arm goes into abduction, the conjoint tendon's new position acts as a sling and also tightens the lower fibers of the subscapularis tendon to stop the shoulder dislocating. Here you see that sling effect in action again as the shoulder goes from resting up into abduction. The conjoint tendon moves into the position of dislocation. See, the coracoid is placed through a split in the subscapularis tendon. Which is the best option? When deciding which surgery to do, we need to consider, first of all, if there is bone loss at both the glenoid and the humeral head. Patient factors that need to be considered are patient age, with younger patients at higher risk for recurrent dislocation and failure of arthroscopic stabilisation, patient activity levels and sporting levels, with patients in contact sports such as footy or rugby at higher risk of failure. And finally, surgeon preference has an influence as well. Nowadays, there is an increasing trend towards using the Latarjet procedure, as long-term studies of arthroscopic stabilisation have shown a relatively high incidence of failure and redislocation. Finally, on dislocation, it is important to be aware that dislocation in the older patient is not the same as dislocation in a young patient. Approximately 20% of first-time dislocations occur in patients over the age of 60, and these patients have a very high incidence of cuff tears, often massive tears. It is important to consider this and have a low threshold for imaging the cuff. Case 3 was an elderly lady who has osteoarthritis. Osteoarthritis is a disease of the elderly, with very few patients presenting below the age of 50. Presents with progressive pain with activity and decreasing range of motion. Patients may have impingement symptoms. Can be associated with previous trauma or previous shoulder surgery for instability or rotator cuff. On examination, patient has decreased range of motion, both active and passive, pain and crepitus at extremes of motion. X-rays will demonstrate the 4 cardinal signs of osteoarthritis as seen here: decreased joint space, osteophyte formation, most commonly that spur which you see pictured on the inferior humeral head, and again subchondral sclerosis, subchondral cysts. Cuff arthropathy is different to classic osteoarthritis. This is caused by a large or massive tear of the cuff. This disrupts the balance of the shoulder joint, leading to superior migration of the humeral head. We see a pattern of superior glenoid erosion and erosion of the acromion. On the right, you see here the humeral head is now articulating with the superior glenoid and the acromion. Management first involves non-operative modalities such as physio, simple analgesics. Cortisone injections may be helpful, but the effect is often temporary. Rest and activity modification should be considered. Surgery is usually the best option for active patients, and the operation is a total shoulder arthroplasty. There are 2 types of arthroplasty pictured here, an anatomic and the reverse shoulder arthroplasty. For an anatomic shoulder arthroplasty to work, the patient needs a functioning rotator cuff. The reverse shoulder arthroplasty is used in patients where there is a deficient rotator cuff, such as patients with cuff arthropathy. The reverse shoulder arthroplasty changes the biomechanics of the shoulder, allowing the deltoid to be recruited and perform the function of the torn cuff tendons. Both operations have excellent results with both pain relief and return of function. Thank you for listening to the talk, and if you have any questions, please don't hesitate to contact me.